All right, good morning, everybody. And if you're from the East Coast like me, it's unequivocally good afternoon, especially since I just got in last night. I'm Mark Olaf. I'll be the only presenter today because my colleague, Dr. Ross Ellison, unfortunately missed his flight, it was canceled. It was delayed, and then canceled last night, and there was no way to get him here in time for today. So I'll be presenting on behalf of both of us. I'm here to talk about the System Triage Officer, the value of emergency physicians delivering value-based care. We don't have any conflicts to disclose, but I will say that I do play the role of one of the System Triage Officers, and I'm compensated for that role. And Dr. Ellison is our medical director, and he gets protected time to oversee the program. So those are our only relevant conflicts. The System Triage Officer is a novel concept that happens to lie at the intersection of two important societal needs: an overwhelmed hospital and ED infrastructure, and a timely need to demonstrate the value and expand the defined role of emergency medicine. The System Triage Officer provides an opportunity to address both of those needs and more. So we know from the pandemic, and we know pre-pandemic, that we've had lots of boarding issues, and this has been a crisis. And it wasn't just the pandemic, right? This is an issue that seems to be here to stay. A poll conducted on behalf of ASAP in September of just last year, 2023, they surveyed 2,100 people across the country, 2,100 adults, and that showed an overwhelming majority, 80% of those individuals, these are people in our country, expressed serious concerns about the boarding crisis. So our patients are noticing that we have a problem. Moreover, 43% of respondents either delayed seeking medical care or avoided it altogether if they anticipated prolonged wait times. We saw this during the pandemic, and we continue to see it now. Nearly half of adults, 44%, experienced long wait times following initial care in an ED, and 16% of these adults reported 13 or more hours waiting after receiving their initial care. This is a big problem that we're dealing with. At the same time, SAEM convened the Workforce Committee just a few years ago, and we've been looking at the landscape of emergency medicine and the services that we as emergency physicians can offer. So in addition to the ED and hospital boarding crisis, we face a critical juncture in the specialty of emergency medicine that's asked us to define and redefine our specialty. So I'd like to draw your attention to a recently published article in Annals of Emergency Medicine, Beyond the Four Walls, the American College of Emergency Physicians 2022 New Practice Models Task Force Report. This article describes the expanding landscape of emergency medicine, and it was work that was created by the task force here. 21 emergency physicians worked to identify 21 established clinical roles, 9 established non-clinical roles, 13 emerging clinical roles, and 13 emerging non-clinical roles. They performed a strengths, weaknesses, opportunities, threat, or a SWOT analysis. And you can see here that they considered patient, system, and community needs, as well as the overlap with emergency physician skills and interests to determine where we had existing and potential new roles. If those needs were met, they were defined by traditional EP roles. If they were unmet, they underwent the analysis, and these new roles were better defined, and then some advocacy was suggested to be done. As we look at those roles that were defined by that task force, there's a couple of them that overlap with the System Triage Officer, and I'll tell you a little bit more as we describe this underlying need. I'll tell you a little bit more about the role in specific here. Existing roles, care transition. So the ARCH System Triage Officer helps with care transitions in a hospital and across hospitals. With regard to the evolving roles, acute unscheduled telehealth, home care physician, and community paramedicine physicians, some of which have been done by emergency medicine physicians across the country, but perhaps not in a systematized fashion. So these are more evolving roles for our specialty. Of the various emerging roles that were defined by the task force, they specifically identified these 5 as priority areas, and the ones highlighted in blue here are all integrated into the System Triage Officer model as we have deployed it. So that includes home-based care services, mobile integrated health, rural emergency medicine, and telehealth and virtual care. So I ask you, what if we can do flight control? What if we can care for our patients or help them find the right place before they come to us? One of the challenges as an emergency physician in addressing getting the right patient to the right care at the right time has been the fact that we are in the emergency department. We do lots of advertising and media and propaganda, things like that, to suggest, everybody probably has the billboard, or you've seen the billboard of, when to go to the ED. We've seen the Instagram memes of, when to go to urgent care. What if we can address ED boarding, hospital flow, and we can influence capacity? What if we can get that patient to the right physician at the right time in the right environment? In my mind, there is never an inappropriate emergency department visit. We're here to care for patients. We embrace the fact that we are the safety net for healthcare in the United States, but we know there's an opportunity to improve upon that. We also know that there's an important need to improve upon that so we can better care for our patients and better care for ourselves while we're working. But what if we can also perform the other things that were mentioned there, telehealth with a patient at home in an urgent care, or provide instructions to mobile health paramedics to care for a patient at home? What if we can avoid an unnecessary transfer? What if we can avoid an ED visit for a patient and save them time and money and be able to offer ourselves to the patients that are in front of us already? So we came up with the System Triage Officer a couple of years ago, before any of this work was done and before the pandemic, quite frankly, to address some of these needs. We saw it as an integrated health system in rural, central, and northeastern Pennsylvania. We saw this need mounting, and we decided to address it. Our System Triage Officer is not patient-facing. They work in our Geisinger Placement Services, or GPS, conveniently, the acronym works out, the abbreviation works out well for us. So GPS is a set of nurses and folks in administration who help with patient flow and bed placement, transfers among hospitals. But that was a nursing-centered kind of, I'll connect one doc with another doc or an AP with another doc. And what we did was integrate a dedicated physician into a role to help with the facilitation of those transfers. But we quickly realized there was more opportunity than just to facilitate the transfers. So what did our System Triage Officer, what was asked of them? What did they do? So we first asked the STO to evaluate the medical necessity of care. Is this a patient that actually needs to be transferred from a community hospital where they're close to home to a tertiary care center? Do they need something else? You might have seen patients in your ED, or if you've ever taken one of these transfer calls, my heart does go out to our hospitalist counterparts. Sometimes, if somebody is just lamenting the fact that a patient has been in their hospital for 2 weeks straight and they can't quite figure out what's going on, but they also can't quite articulate why they need to come to your hospital other than I've ran out of options. They're in a dilemma, but we're also in a dilemma at that point. So in those cases, we decide whether that transfer is necessary, and we might invoke some of the specialists, some of the services they're asking for. And the STO plays a middle role there. And you might think initially, well, geez, I don't really want to be in the middle of that. What you're really doing is articulating one of the conversations and trying to narrow it down to questions that we ask every day. What is the problem, right? What is the reason that this patient needs to be admitted or not admitted? That's something that we have in our skill set. In addition, the opposite end of the spectrum there, we expedite transfers. Patient clearly has, upper GI bleeding and needs a scope of some kind. It's only available at a certain center. Yeah, absolutely, we'll facilitate that. They have a biliary, they have a choledocholithiasis and ascending cholangitis. Yep, we'll bring you to get your ERCP tomorrow, whatever the case is. So we can expedite those when the answer is quite obvious. We can also provide consultative and triage services for our urgent care centers. Again, we're an integrated health system, so we have a number of urgent care centers that kind of fall under us. And we also have what we call convenient, those are convenient cares, and we have convenient care plus is a bit of a boiled down freestanding ED. But what we can do is have those folks either connect through the transfer center, or we use Tiger Connect as our secure messaging system. Those folks are encouraged, and in fact, we would use the term mandated. Before they send a patient from an urgent care to an ED, they're supposed to Tiger text the STO to say, here's what the problem is and here's why I can't do it. And sometimes we're actually able to, quite frequently, we're actually able to help that AP work through the problem and take care of that patient, be able to send them home and find care later on. Because what they're really doing is trying to send it for some more expert opinion. We're here to help them with that opinion. We also provide medical command for mobile integrated health. And we were fortunate to receive a grant a couple of years ago, in 2020, I believe it started, with the ET3 program. And so we were actually able to provide telehealth services, mobile integrated health oversight, and medical direction for our mobile health paramedics, and actually allowed our system to bill for patient care that was rendered on-site by EMS, both from the physician standpoint and from the EMS standpoint, or with an alternative direction, alternative site for that patient. So not every patient that was getting cared for by EMS had to come to an ED, and this really opened up an opportunity to allow the STO to help facilitate some of that care. These are all of our system triage officers are all EM physicians, and all of them are EM boarded. And what we do is staff this from 8 a.m. to 8 p.m. 7 days a week. And that was our initial model, and we found that it went so well and we had such a high need that we opened up another shift that goes from 12p to 8p on weekdays. So that's the type of work that they're doing. So where does this add value? So I think some of it's pretty intuitive from what I've talked about already. Urgent care referrals, right? Are patients coming to the emergency department for additional care that they absolutely need, or is it because it was at the end of the comfort level for the AP that might have seen them in urgent care? Again, an integrated health model where we've got patients that are under the same insurance platform as our system is, if we can avoid an ED visit, that's a cost savings to the system, it's a time saving to the patient, and again, the value is emphasized there for everyone. We can also look at modulation, So what I will sometimes do when I get one of these calls is I will look at the ED capacity for various emergency departments in the region, and I'll help direct that patient to the right ED at the right time, It's, to some degree our volumes are somewhat predictable, but in a moment to moment or day to day, they aren't perfectly predictable, so we can help with modulation of care and appropriateness. As mentioned before, we can do telehealth, and we can optimize tertiary care utilization. So in terms of that capacity and utilization, we can provide video, photographic, telephonic consultation and avoid the ED about 40% of the time with these urgent cares. And when it comes to tertiary care transfers, we can actually avoid about 45% of the transfer calls going through the ED. They become direct admissions. Hands in the room. Anybody ever had to take outside of the ED, anybody ever had to take a phone call transferring a patient from one hospital to another as an inpatient anyway? It's kind of nightmarish, right? I don't know if you guys, I'll just put it out there in my opinion, but it's pretty bad. To save our inpatient counterparts, our hospitalist folks and surgeons, some of the time for this, the value and just the camaraderie that builds is also something that's pretty not quantifiable, but very important. I've also found that another kind of intangible value is with our AP providers in the outlying clinics, and then also the EM docs. Sometimes you just know that patient is sick enough that they need to be somewhere and they probably need a couple of things, and the STO can then help that stuff happen so you can go get back to taking care of your waiting room of 20 people in your 10-bed ED, right? So there's added value there too. So how does this work? So I mentioned before, some of our APs can connect with us through our Tiger Connect process and reach out, and many of them do that. But we also have a one convenient kind of phone call process. So the referring provider calls the transfer center nurse connects referring provider with a system triage officer, have a discussion. The patient's accepted by the STO. So my name is the one going on saying I accepted it or I declined it. Sometimes there's a pause there. Sometimes I go to the interventional radiologist and say, you want to put a drain in that diverticular abscess? They get back to me and they say, nope, doesn't need one. Okay, problem solved. Home on antibiotics, or stay in the hospital that you're at. Perfect, we've got the expert involved. I'm not at any degree of higher risk, nor is the EM physician. We're not in that model of let me just transfer to mitigate some risk. We already know what we're doing for the patient. It's great. If they do have something that's needed, I've already talked to the IR guy or girl, and I say, bring the patient here. I let the hospitalist know, hey, IR is on board for this diverticular abscess, needs some antibiotics, or the surgeon, whatever the case may be. I let the transfer center nurse know if they assign the bed, and we're off to the races. So that's generally how it works, and it does go generally that smoothly. Every once in a while, we hit some hiccups. Does the patient need the ICU? Do they need the floor? It can get a little bit complicated. For reference, here's our service area. So we are in Central and Northeastern Pennsylvania. Our primary kind of service area is in the dark blue, and then secondary is in the lighter blue. We use that to help inform some capacity decisions. So when the tertiary centers are kind of overwhelmed, we can kind of, we can always say we don't have capacity. We treat STEMI, strokes, and traumas differently. We always have capacity for trauma, especially given our geographic region with limited trauma centers, but generally the same with strokes and STEMIs, and we are a comprehensive stroke center as well. That highlighted area there serves about 6.7 million people and covers a large portion of the state. In terms of our ED volumes, you can kind of see we're just shy of 300,000 ED visits across the system. And if I go back one slide, that extends all the way from generally in Center County there in middle Pennsylvania, all the way up to, we actually, it's not a Geisinger-owned hospital, but we staff in the emergency department up here in Wayne County, a little star right there. And it's about a 170-mile drive, from one end to the other, 3-ish plus hours. So it's quite a bit of geography that we cover. Our call volume, so how does this make sense for us? So these are the call volumes, and there's two different elements. You could actually layer these on top of one another. You can kind of see that they match fairly well. So over the course of 2023, we see the number of calls from convenient care. So these are the urgent care calls in the blue lines. You can see upwards of 350, sometimes as high as 450 calls or contacts. Those are sometimes the Tiger Text contacts. The transfer center, I'm calling with the intention of transferring a patient. You can see pretty similar. We dip down a little bit below 350 there, but pretty consistently in that area. So roughly, 700 plus calls per month to do this. We calculate what we call an ED avoidance rate, so you can kind of see what percentage of patients are somehow found another destination other than going into the ED. Again, this helps with modulation. It helps with value for our patients. You can kind of see that somewhere around 35% or a little bit higher, we can actually avoid the ED. So what does this translate? Dollars and cents, right? So this is what people, how are you going to pay for this thing? How are you going to take an EM doc and put them in a seat and let them do this work? So our system, there's a bunch of background that Dr. Ellison is more in the weeds on, quite frankly, but the bed capacity that they value that these opportunities would generate would be about $3 million of cost, and again, integrated healthcare system. The program itself costs about $1.2 million. So total financial impact is actually on the positive. We saved $3 million. The operating the program cost 1.2. So the net savings there is about $1.8 million. So we've basically shown this to be a profitable program where we're not losing money due to a patient being transferred in, holding a bed, only for the specialist to kind of see them the next day and say, nope, you don't need surgery, or nope, you don't need your IR drain, right? We avoid that, and that's where that bed value capacity contribution comes from. So in conclusion, we see a net positive financial impact. I can speak for myself about, as a physician and provider satisfaction. I mentioned before about some of the APs that really use this kind of process pretty heavily. But as somebody who has worked in this role, I'd say it's really satisfying. It's work that's a little bit abbreviated. It flows very well with EM kind of work. And I say reduce burnout and extend career. One of our most senior physicians, working on 25 or 30 years of practice plus, he has transitioned exclusively into a role like this. And for him, the benefit is that he's extended his career and gets great satisfaction out of it. And he's got family all across the country, so what he actually does is travels all of the time, and he does this as remote work. And that's something that's been very satisfying for him and really opens up a new door, right? When's the last time you saw an EM physician doing EM-related care entirely remotely? I mean, certainly there's urgent care models, but this is something that's a little bit innovative and creates an opportunity. And then we improve capacity for our health system. We improve ED capacities. We modulate those visits. So that can be really, really helpful. And that's what we found. Happy to take any questions. I was basically just here to kind of share some of that data and the model. I realize it won't work for everybody. Certainly it works for us because we're an integrated health system. We have a pretty defined geography and landscape. But I'm happy to take any questions. And thanks. Sure, yeah. Yes.
They don't do anything, and then they're stuck in my ED after a $30,000 helicopter ride.
Yeah.
And get back where they came from.
Yes.
I wonder if there's a way to apply this to other non-integrated systems.
Mm-hmm.
A lot of it probably has to do with the telemedicine model and being able to originate excitement where you can initiate that.
Right.
But how logistically, when you had to work with a specialist, so not just the urgent care, but someone who maybe had a burn on their hand that doesn't really do the furniture,
Right.
Vaseline on it, are you then calling the burn surgeon, sending pictures? Like how much time does that take, and how quickly are you able to get a hold of
Yeah.
that?
That's a great question. So the question basically is perhaps in a not so integrated system, or when you have to include that specialist, how is that all happening? So what generally we're doing is, for the most part, if there's a picture available, if there wasn't a picture, I get the provider to send it to me and say, yeah, I'm happy to be the middle person here. You go back to taking care of your waiting room full of patients, right? So now the case is kind of in my hands. And then if I have a burn surgeon or whatever the case may be, I'm sending them the picture and the detailed information and letting them make their decision about whether that needs transferred or not. So in a non-integrated system, before I would accept that patient from remote somewhere, I would just say, just hold there. If it's critical, you shouldn't even be talking to me. We'll figure this a different way out, right? Or I'll just say yes. But for that, and sometimes that actually means putting everything on pause until that other person gets back to me. So sometimes we've got cases floating in the background, just like sometimes our patients might float in the background for 2, 4, 6, 8 hours. Sometimes it's, I don't know, and we're going to do this tomorrow. But those are all non-acute, we have some time, and so we just find a way to integrate that other person in there. Another question in the green back?
I'm curious, because we were trying to do this, last general, we were trying to do the transfer coordination.
Yeah.
And general counsel had been very clear to us that we were not, if we were going to be going into the other hospital and doing that transfer calling, we had to be credentialed at that site. If we were going to look into that EHR, we were starting actual presence or the appearance of a patient-physician relationship.
Yeah.
So it's not as much us, it was going to be another hospital.
Sure.
Untoward happened, and someone who was providing care advice at the active time was not credentialed at the facility.
Yeah.
So even through an integrated system, these were in our system, but yet they have different bylaws and different credentialing.
Yes.
Physician organizations. So did you guys?
We are cross-credentialed across all of our hospitals.
So awesome.
Yeah.
And then, and so general counsel is okay, I'm assuming, because for us too, is we also would like to have that burn surgeon see them.
Right.
And they, Friday before I go live, we finally got a chance, right, to talk to our telehealth group, we got to talk to the manager themselves.
Sure.
And they said, no, they can't look at the images, right? They're going to need all the urologists, all the burn surgeons, all the travel care surgeons, all the
Yeah.
and neurosurgeons that want to see the images, maybe not the video, they need to be credentialed. So cross-credentialing is.
Yeah. So, I mean, all of our EM physicians are cross-credentialed, so kind of pooling that information, and now it's like a patient that I'm effectively caring for, so you're involved in their care. Just like that's a little bit of, in my opinion anyway, kind of, you're really, that's some interesting semantics, because in my mind, you can invoke EMTALA pretty quickly here, right? You're looking for a service that's not provided at your hospital that you as a doc decide that the patient needs, right? So in most cases, EMTALA is invoked. And at that point, the place at the tertiary care center is now involved in that patient's care, to some degree, right? And determining whether that care needs to happen or not, So I think there's an interesting way to look at that. But for us, in terms of looking at least as the STO, because it's all EM docs and we're cross-credentialed, we at least have that capacity. And then whatever we're pulling out, we're sharing with a consultant. So, yeah. In back there?
Right now, great talk.
Thanks.
How did you train for this role?
Yeah. This was a little bit of like building the airplane as you're flying it. The ET3 thing rolled out while we were doing this. Initially, it was just supposed to kind of take a little bit of burden off of the EDs and the hospitalists. Quite frankly, that was it. It was like, let's put somebody in the middle to accept or decline transfers, mostly from within our own system. So it was just bridging that gap so the hospitalist can just focus on the ED admissions or the patients that are on the floor or whatever the case is. And to decide which patients really did need to be transferred, because we're talking about moving people just like you guys are, right? By a helicopter, 200 miles from home or something like that. And so that was where the initial impetus was. Then we layered in the other parts of this with, ET3 and some of the convenient cares and things like that. So there, as we all learned, we would have a monthly staff meeting that just takes 1 hour, and we would just share our ideas. What went well, a little bit of kudos here and there for, hey, I talked to a GI doc about this thing, and we can kind of standardize something, or sometimes creating new roles in our Tiger Connect system so that you knew who to talk to. So it was a little bit of just kind of building it as we went. Yeah.
Thanks for presenting this. My guess is that most of the emergency physicians at the referring side are okay, but eventually these people have to get admitted and inevitably they end up with
Yes.
medicine.
Yeah.
I guess,
Yeah.
What kind of buy-in did you get from the hospitalists and those groups of saying, oh, well, this surgeon says they don't really come, they can sit on.
Exactly. And sometimes that gets a little bit tenuous, and sometimes those are the cases that we'll say, oh, the specialist doesn't think so. I even had the case of a urologist at the sending hospital saying, don't keep it here. The hospital saying, well, they said don't keep it here, but the urologist at my hospital saying it doesn't need to come. And so now you've got like all these differing opinions. sometimes, getting back on the phone and out of the tiger text mode, right? So out of texting, bringing a little bit more emotion and conversation to it helps quite a bit to kind of de-escalate. Again, another skill set that EM physicians have. And sometimes it's saying, you know what, they're not unstable and there's nothing that they're going to do. Can we, sit on them for another 2 hours in the ED? As much as we try to expedite all this, sometimes it's, let's just sit and watch. Let's get another set of vital signs, another set of whatever, or admit them overnight and we'll readdress this tomorrow, right? Everybody is aware and we'll handle it then. So. One more in the back.
Hi, Samir Hyder from the Medical Center. Our system recently became 11 hospital system, and we have what we call one-call central. We talked about the position there. My question is, staffing model-wise, is this an opt-in 1 month, one shift a month?
Yeah.
The second question is, are you being reimbursed as
Mhm.
an emergency physician while you're in this role?
Yeah.
Or is the hospital like paid?
Yeah, so great question. So one is this an opt-in? Yeah, so these were only people that wanted to participate in the program kind of opted into this, and it's basically done above any contracted EM hours that you have on your schedule. So this is kind of moonlighting essentially. After this thing got off the ground a little bit and we saw the value in it, we then created two, they're not 1.0 FTE, but they're partial FTEs for these roles, and we now actually have 3 of those people. One is a full one-time 1.0 FTE, and then there's 2 other individuals that just have like a 0.3 and a 0.4 for this work. That comp is different than the EM rate. It's about 65% of what the EM clinical rate is. So it's still good money, but it's not the same. I think that answered all your questions, yeah.
Is the per diem rate above?
It is, yeah. So if I pick up an STO shift, and the other nice part about this is like we have 8 hours or 12 hours, I can only do 6. We actually had to move to a model where we have an administrator release the schedule at midnight on the 1st of the month because people scramble for these shifts so much. We have a little bit of like infighting almost. We just had like an Outlook calendar we were doing, and people were only supposed to go out like 2 months, and they were going out like 5 months because people like doing this work. So we had to switch to a different model, but everything is above your contracted rate. It's all just moonlighting for folks.
Are you getting paid as a physician? It's like a per diem, like not the full time?
Yeah. So all my EM work I get my salary for. If I pick up an STO shift, I get $170 an hour. That's the rate that we're doing it at. Yeah. But that's not our clinical moonlighting rate. That's less than that. All right. I'm pretty sure I'm over. I don't want to ruin. Is anybody else on? Were you on at 11:20 or 11:30? 11:30 is the next one. Okay. So we got time for one more question then. Yeah.
Similar problem, we just picked up 5 months old underused airline, and we are looking at the opposite questions. We're bringing in the higher acuity, the mothership.
Right.
Have you had any success moving the moderate and low acuity to some of the other community
Yeah.
to decompress and liberate those resources?
Yeah, we do that as well. So when we get folks at the tertiary center that don't need those services, right? Somebody that's old and frail, failure to thrive, needs nursing home placement, rehab, something like that. We do use this process to kind of get them to neighboring places. We see a little bit less success with that because sometimes those people showed up at the tertiary place because they want to be there, and we always defer to the patient's preference, of course, and so we don't see as good movement with that, unfortunately, yeah. We are individually licensed with a couple of dual, kind of 2 hospitals under the same license. Yeah. Anything else? All right. Thanks, everyone. Appreciate it. Thanks, Brandon. Thank you. Yeah, thank you.